My name is Chirag Shah. I'm a radiation oncologist. I serve as the director of breast radiation oncology at the Cleveland Clinic. In patients who undergo mastectomy that are clinically node negative and subsequently found to have a sentinel lymph node involved, much has changed with regards to axillary management. Classically, patients who had a positive sentinel lymph node underwent axillary dissection with also consideration for adjuvant radiation therapy. However, two trials have asked us to reconsider that thought process. The first trial was the ACOSOG Z11 trial, which included only patients undergoing breast conserving surgery. These patients were all clinically node negative and were randomized to axillary dissection or radiation therapy, though regional nodal radiation was not specifically allowed for in the study. The study with long-term outcomes found no difference in rates of recurrence at 10 years, though it was found that up to 15% of women in the radiation arm had lymph node radiation given beyond whole breast radiation. A study performed in Europe evaluated the same question, and that was the AMAROS trial. The AMAROS trial looked at clinically node negative patients, with the majority also having breast conserving surgery. Following a positive sentinel lymph node, patients were randomized to axillary dissection or radiation therapy that also incorporated regional nodal irradiation, unlike the ACOSOG trial. This study has also been presented with long-term outcome, demonstrating no difference in rates of recurrence, with reduced rates of complications, particularly lymphedema, with axillary radiation therapy as compared to axillary dissection. While these studies did not include a large number of patients undergoing mastectomy, given that the concern is axillary management, it's very appropriate to extrapolate this paradigm to patients undergoing mastectomy. For my practice, if I have a patient who is clinically node negative and undergoes a sentinel lymph node at the time of mastectomy is found to be positive, I commonly offer axillary radiation in lieu of axillary dissection. Some exceptions to this include patients with gross extracapsular extension, those with 4 or more lymph nodes involved. An additional consideration in patients undergoing mastectomy found to have limited nodal disease is the role of reconstruction and radiation therapy toxicity. Therefore, an informed discussion is often important with the patient, discussing the potential for omitting radiation therapy if a solitary node is found after dissection, as compared to omitting the axillary dissection and giving regional nodal radiation in conjunction with chest wall radiation, which may increase reconstruction toxicities.